And so next we're going to move on to the hot off the press bladder cancer. I know every time we have a GU conference, bladder cancer just takes it away. So tell me about EV-302, which is an updated analysis from that phase 3 global study of enfortumab vedotin in combination with pembro versus chemotherapy in previously treated or previously untreated locally advanced or metastatic urothelial carcinoma.
So we heard about this first at ESMO 2 years ago, and this is an update from that groundbreaking EV-302, which changed our standard of care in first-line bladder cancer, and it continues to show significant PFS and OS benefit. So the PFS was 0.48, so 12.5 versus 6.3 months, and the OS of 0.51. So the median OS is greater than 2.5 years, so 33.8 months versus 15.9 months. The overall response rate was 67.5% versus 44.2%, with a duration of response almost 2 years for the responders. So that's really phenomenal. And then 30% of patients had a complete response, which is amazing, versus 14.5%, with the duration of complete response not reached versus 14.5 months. So they also described that of those that achieved a CR, the probability of maintaining a CR was 74% at 2 years. Also amazing. The grade 3 adverse events were 57% versus 69%. And so this demonstrates the durability of those with a complete response and does beg the question of the consideration of de-escalation or treatment breaks for those that achieve a CR.
Yeah, definitely. So EV Pembro still first line, still beat out chemotherapy. And now the question is how long before you guys can start backing off since you guys got that good tail of the curve going for OS. And so next, can you talk to us about CheckMate 274 updates? And so this is adjuvant nivolumab versus placebo for high-risk muscle-invasive urothelial carcinoma. And this is additional efficacy outcomes, overall survival in patients with muscle-invasive bladder cancer. So this is that CheckMate 274.
Yes, so CheckMate 274 continues to show both the disease-free survival and overall survival benefit, regardless of treatment with neoadjuvant chemotherapy and also regardless of PD-L1 status. There were a few caveats. So how can we avoid over-treatment? In the future, can we use different biomarkers such as ctDNA, PD-L1? We have the modern trial, which is going to help answer this in the perioperative bladder cancer space. Only 50% of patients in the CheckMate 274 got standard neoadjuvant chemotherapy. And although the majority of patients received immunotherapy at progression, if they were in the control arm, patients wouldn't have been receiving EV Pembro because this was conducted before the EV Pembro approval. And so there's also a question of, can we use sub-Q Nivo in the future? Because there's a lot of interest for maybe using something that might be quicker instead of needing an infusion chair, because it has shown clinical equipoise to standard IV dosing and may provide an alternative to patients in a variety of tumor types.
Yeah, that's very cool. We always like to have new and easier ways to administer our drugs. And so what about the abstract 659? And so this was covering the Niagara trials, and this is additional efficacy and safety outcomes from the Niagara trial, as well as this exploratory analysis of the pathologic complete response and that impact on long-term outcomes. Can you go through that with us?
Yes. So this was an update of the Niagara trial presented this past year, and this is not yet FDA approved, but for many, it's considered to be the new standard of care for patients with cisplatin-eligible muscle-invasive bladder cancer. There was a continued event-free survival and overall survival seen in both those that achieve a path CR and those that did not achieve a path CR. It's still unclear on who benefits from the adjuvant immunotherapy portion of this regimen. Because of the sandwich approach, they didn't tease out that question, particularly for patients that achieve a path CR. Do they really need that adjuvant durvalumab? But we don't know the answer to that. As I mentioned, we have the modern trial, which hopefully is going to help explore that, of course, with different agents. And there's a few other questions that still remain with Niagara in terms of what happened to the patients that did not undergo cystectomy. I think there was about 15%. And how many patients in the control group got adjuvant immunotherapy as per the CheckMate 274 regimen that we just talked about? And also the same way that what is the role of continuing durvalumab in those that have a complete response? What is the role of continuing it in non-responders? And then the discussion was really great by Dr. Plimak, and she also suggested that Dostans MVAC was a reasonable approach with adjuvant nivolumab for those that meet the criteria. So there's still some consideration, but it was exciting to see continued efficacy for this regimen.
That's awesome. And so I know you were involved with a poster, and this was a survey-based study on the treatment preference post EV Pembro. So tell me about your poster. Walk us through it.
Yes, so I was a co-author with Dr. Chablani, Dr. Kaki, Dr. Grivas, Dr. O'Donnell, among others. And so we surveyed oncologists in the US, and we had 71 oncologists respond. They were primarily in academic settings and saw more than 25 patients with metastatic bladder cancer per year. And most providers favor platinum-based chemotherapy without concurrent immunotherapy and without switch maintenance immunotherapy in the second-line setting post-EV Pembro. So we don't have guidelines yet on what to do post-EV Pembro because of the fairly recent approval. And they would also consider erdafitinib for those with FGFR3 alterations.
Great.
When we asked providers for clinical trials if they would favor a immunotherapy containing regimen or non-immunotherapy containing regimen, most favored a non-immunotherapy regimen, presumably because of negative immunotherapy rechallenge from other GU cancers, such as in kidney cancer. And we do need more information in terms of how many patients actually qualify for platinum-based chemotherapy in the second-line setting, because we know that performance status can be impacted in the second-line setting. We know that residual neuropathy can be an issue in terms of giving things like cisplatin or carboplatin in the second-line setting. And we also don't know about the impact of HER2 approvals in this space, because shortly after we released this survey, there's been now the approval of TDXD for those with IHC 3+ metastatic bladder cancer.
This is an exciting poster since you're kind of creating or asking the question of what is going to be the treatment algorithm before, it truly rolls out and what people are doing. So this is awesome that you guys did this great survey based to look for real life treatment plans of what people are doing. That's great.